Hello everyone. I'm going to do a video on advanced lower extremity muscle identification out of, again, your green Segan Adams textbook. So if you would please grab that and also your list of lower extremity muscles, and we will go through again the more important points of this. I don't plan on reading all of the origin, insertion, action, and innervations for you. I know that you can do that. I'm just going to try to bring some information and help you link information for your learning purposes. So first, I would like you to look on page 128, and this is the lumbosacral plexus, very similar to what we saw with the brachial plexus for the upper extremity. These are the spinal nerve roots that are coming off of the spinal cord, starting at T12 and coming all the way down. And then as those nerves network out into the periphery, they become the peripheral nerves of the lower extremity. On page 129, you'll see the obturator and the femoral nerve. And you can see that the obturator is coming right down the anterior location through that obturator foramen, and then it continues on to the adductors of the thigh. The femoral nerve, it passes underneath the inguinal ligament, and that's when it changes its name to the femoral nerve. Page 130, you have the sciatic nerve. That, of course, is the large peripheral nerve in the posterior thigh. And you see how it has a fibular, also could be called a peroneal division, and a tibial division. So the tibial would be traveling on the median side of the lower leg. The fibular would be traveling on the lateral lower leg. And then you see on page 31, the fibular nerve, also called the peroneal nerve. So let's bounce back and begin our discussion with the glutes, gluteus maximus, which is on page 97. So we'll kind of look at the gluteals together. The maximus, you'll note that it crosses two joints. And it inserts that, there we have that IT band, the lateral most structure on the lateral thigh called the iliotibial band. You see its origin on the posterior aspect of the ilium and the sacrum. It inserts on the greater tuberosity of the femur and the IT tract. And you see the actions are extension of femur and lateral rotation of an extended hip. So that you would have to take your hip back and then laterally extend it to see its action. Then you see the innervation, inferior gluteal nerve, L5, S1 and 2. But once again, the real functional aspect of the muscle is down in that box. So let's read it. Gluteus is Greek for rump. So we have the three gluteal muscles, maximus, medius, and minimus. The gluteus maximus is the most uses the most power, as in going up steps and rising from a sitting position. So sit to stand, when you're coming up, you're using your gluteus maximus. Also powerful for climbing and running. So if you visualize a person on a rock wall and having that hip up to the next step and then pushing up to get to the next rock, that is the action of the glute max. And it mentions that it's not super powerful for walking. So, there is that distinction there. So once again, if you had just focused on the traditional actions, you really would have missed what the gluteus maximus really does in terms of its function. Then over on the next page, we have gluteus medius, very important muscle. And the box will tell the rest of the story. You have the origin, insertion, again on the greater trochanter at adducts, and the anterior fibers medially rotate the femur, superior gluteal nerve, L5S1. But let's look at the box. You will see this concept again and again this semester. So when standing on one leg, the gluteus medius contracts on that side, so the side that bears the weight, to help stabilize the pelvis and prevent it from tilting on the unsupported side, or the side that does not have weight. Paralysis of this muscle on one side results in gluteus medius limp, or also called a Trendelenburg gait. The pelvis tilts toward the uninvolved side during walking. When you're standing on one leg, the fibers on that leg must contract with the gluteus medius. Otherwise, you will see a tilting down of the pelvis on the opposite or the contralateral limb. And so the side that is bearing weight is the side that you are testing if you're looking at gluteus medius or Trendelenburg sign. It's a very important concept. And then gluteus minimus, you see the origin, insertion, action, innervation. And then down in the box, gluteus minimus works with the anterior gluteus medius to steady the pelvis during ipsilateral weight bearing. So ipsilateral means same side. So if you're standing on the right leg with your left foot lifted, it's the right glute med that it's working to hold the pelvis level. If the right side is weak, the pelvis will drop to the contralateral side, which in this case is the left. So if you have trouble with that, please let me know and I will explain that further to you. We can do some examples. The tensor fasciae lata is on page 100. You see the origin, insertion. Again, it inserts along the IT band, the iliotibial tract that attaches to the lateral condyle of the tibia. It's not a real strong muscle. You see that it assists in all of these actions. So it assists with flexion of the femur, abduction of the femur, medial rotation of the femur, and it assists in stabilizing an extended knee during standing and ambulation, and it assists in knee extension. So it has an important component during gait, because as soon as that knee extends, it's going to act to help stabilize it. And then you see down in the box, the TFL extends as the iliotibial tract and attaches to the tibia. It tightens the fascia and helps stabilize the hip and knee. So that is an important muscle that does become injured with activities such as biking and running, IT band syndrome. And then on page 100, we get to the 6 deep lateral rotators of the femur. The gemellus superior, obturator internus, obturator externus, gemellus inferior, quadratus femoris, and piriformis. Now, the only one of those that I really want you to carry forth on knowing the name, otherwise you can just learn them as a group of the 6 deep lateral rotators. But I do want you to remember that the piriformis is in that group. Remember that one by name. And you'll see here in the picture and then down in the box, this is important because the sciatic nerve lies between the rotators and the piriformis, and it can become easily entrapped in this area. So if a patient has piriformis spasm, it can actually clamp off the sciatic nerve. And in that case, the patient would have radiating symptoms down the posterior thigh, very similar to what we could possibly see from a herniated disc. And so this would be a differential diagnosis. But because the sciatic nerve runs in such close proximity to the piriformis, that's why I want you to remember the piriformis, and then you will see that in the clinic a lot, that piriformis syndrome, where there is spasm and tightening. And in lecture, we'll look at some ways that you can stretch that. The hamstrings are over on the next page, beginning on page 102. And you'll see that they really have 4 heads. So it's kind of like the posterior thigh has 4 large muscles in the quadriceps from the front. But the difference here is that the biceps femoris has the 2 heads, and then you have semimembranosus and semitendinosus. So you can go through those. Those are the large thigh muscles on the posterior thigh. They all have attachment at the ischial tuberosity. And so we've talked about the fact that during skiing injuries or any injury where there's a lot of contraction by these muscles, it can pull away a little piece of that ischial tube and result in an avulsion fracture. They do cross both the hip and the knee joint, so make sure that you get both actions. One head of the biceps femoris will laterally rotate the tibia, the other one will medially rotate the tibia, so make sure you separate those out. And unfortunately, the innervation for the biceps femoris, it actually has 2 different nerves. The long head is from the tibial division and the short head is from the fibular division, but they're all L5, S1, S2. Then on page 103, you see semimembranosus and semitendinosus. You can go through and get all of that information. I would like to point out that semitendinosus, it'll be the semimembranosus is one of the 3 muscles that inserts on the pes anserine. And so there are 3 of those that insert on the medial proximal condyle of the tibia. So semimembranosus is one of those. So the hamstrings are very important. They tend to be weak at times. There is a ratio between quadriceps and hamstrings. I believe it's a 3-to-2 ratio, with the quadriceps being stronger. Hamstrings can become weak, and that can actually be a predisposing condition for things like ACL injuries. And there are ways that we can test that. So we'll talk about that a little bit more in lecture. Before we go on to the next page, let's go back and pick up, let's look at sartorius on page 89. This is the most superficial muscle that you can see in that upper medial thigh. You see the origin insertion, the actions, they're all assisters, femoral nerve L2, L3. This was named for a sartor, the way a sartor sits, which was a tailor. And so when you take your leg up and out and sit like in a cross-legged fashion, that's that muscle that's working. And so you can perform that motion and hopefully break it down and get all of the actions. It also inserts on the pes anserine, the medial proximal tibia. And the third one will be gracilis, so we'll get to that in a moment. Iliopsoas, we combine the iliacus with the psoas major. You can see those there. They do cross 2 joints. So they're going to flex the femur, and then they do flex the trunk because they've got attachment up here on the spine. This is one where it's innervated by either directly off the spinal nerve roots for psoas major or the femoral nerve for the iliacus, but we just have you combine those. So this would be the strongest hip flexor. It's going to be active during gait as you flex your hip and start to bring your foot forth. On page 91, you see the quadriceps. There's only one quadriceps muscle that crosses two joints, and that's the rectus femoris. The others only cross at the knee, and so you'll see on page 91 that it extends the knee and it assists in flexion of the femur or the hip. It flexes the hip. They all come down through on top of the patella, through the patellar tendon, and then come in and insert on the tibial tuberosity. So all four of them will do that. And it just talks a little bit down in the box about combined actions to bring the leg forward in walking, and it extends the knee in such things as jumping. And then you see the vastus lateralis, the vastus medialis, and the vastus intermedius are the other three quadriceps tendons. The origin will be slightly different. The insertion will all be the same. Crosses over the patella, becomes either you'll see it called the patellar ligament or the patellar tendon, and then it inserts on the tibial tuberosity, femoral nerve, L2, L3, L4. The medialis tends to go silent with knee injuries. So one of the ways that we can target it is prior to the patient performing knee extension, we have them squeeze a ball to get that adduction, because the vastus medialis fibers will also blend in with the adductors. So we can have the patient adduct the knee by squeezing a ball and then performing a knee lift. Pectineus, there's nothing real special about that one on page 93. It's part of the adductor group, but I don't really see too much there that I want to draw your attention to. And then we get into the major adductors. So page 94, you have the adductor longus and brevis. The origin insertions are pretty much the same. I think we have you learn them pretty much the same. They obviously are named after their action, so they adduct the femur and they assist with hip flexion. The adductors are innervated by the obturator nerve, L2, L3, L4. And then adductor magnus, this one does cross two joints, I believe. So you'll see, and it's even so broad that the anterior fibers have different actions than the posterior fibers. And this one is special because the anterior head is innervated by the obturator nerve and the posterior head is innervated by the sciatic nerve. So they have two different innervations. It's a very broad muscle to adduct the femur. And then the next page, 96, is the gracilis. This would be the third muscle that attaches to the pes anserine or the medial proximal tibia. You see it there, it's very superficial and can be seen with like figure skaters, or that's whenever I've noticed it. You see its origin on the inferior ramus, inserts on the medial proximal tibia, which is also called the pes anserine, adducts the femur, assists in knee flexion, and assists in medial rotation of the tibia when the knee is flexed. Obturator nerve, L2, 3. We've already gone through the glutes, So I'm going to pass through those. Talked about hamstrings. Let's look at tibialis anterior next. This has both orthopedic and neurological implications. Orthopedically speaking, this muscle can become very irritated and contribute to shin splints. If you've ever had shin splints from running, its neurological implication is that it prevents foot drop. And so after a patient has had a stroke or traumatic brain injury, that foot may drop down because the tibialis anterior is not there to lift the foot. And so from 120, we talked about a way that you could hook up a heel switch and have that fire as the patient steps through. But because it inserts more medially, it's also going to invert the foot. So it does dorsiflexion and inversion, deep fibular or deep peroneal nerve, L4, L5. And you see that down here in the box. The tibialis anterior is the strongest dorsiflexor, very, very, very important for gait, and allows the toes to clear the ground for ambulation. Paralysis of this muscle will cause a foot drop. That's a problem for gait, during gait, and shin splints are the orthopedic side of it. The interesting thing about then the tibialis posterior is that it is a plantar flexor, but it will also perform inversion. So you have that sort of grouping with the posterior tibialis and the anterior tibialis. They have opposing actions through dorsiflexion and plantar flexion, but they both will invert the foot. And then we get into all of the extensor digitorum longus with the toes. And I would just like to point out that these tendons are long and strong enough that not only do they have action at the toes, but they will also assist with ankle motions. And so, make sure that you're getting those. The extensors will assist with dorsiflexion, and the toe flexors will assist with plantar flexion. And then we go through here. There's not too much really I want to emphasize there. On page 107, you see fibularis tertius. That sometimes is also called peroneal. And so you just have to remember that fibula and peroneal both mean the lateral side of the foot and ankle. So hopefully, you will be able to interchange those two terms. And there are three peroneals that give us eversion, and they assist with plantar flexion. So those are there. And then the very important muscles of the gastrocnemius and the soleus. So since gastroc has two heads and soleus has one, this can be called the triceps surae. Triceps meaning three, surae meaning the distal lower extremity. And so since the gastroc crosses the knee and the ankle, you will see that it has two actions. It's a strong plantar flexor of the ankle, and it also assists with knee flexion. Tibial nerve S1, S2. Down in the box, you can see that it is very active during running and jumping. So powerful plantar flexion when that's needed. It's also very active during gait for push off, when the heel pushes off the floor. And then the soleus is on page 111. It has the same actions. It's a plantar flexor of the ankle, but it does not cross the knee, so it does not have action at the knee. Tibial nerve S1, S2. After this video, let's make sure that we know how to distinguish the stretching techniques between the gastroc and the soleus. There are different things that you have to do for that. Page 112 was the posterior tibialis or tibialis posterior. Again, I talked about the force couple performing inversion with tibialis anterior, but this one is a plantar flexor and the other one is a dorsiflexor. And then we get into the flexor digitorum longus and all of the flexors of the toes and the big toe, the great toe. Trying to think, popliteus on page 115, it's the key that unlocks the knee. It's just this little slip of a muscle down here on the posterior thigh. So it laterally rotates the femur to unlock the extended knee and to initiate knee flexion. So that's very important during gait. It's the key that unlocks the knee to initiate knee flexion during gait. And the rest of these, I think we've had you learn a few of the intrinsic muscles of the foot and toes, but not very many of them. I think you could get the actions, again, something like flexor hallucis brevis, hallucis meaning great toe, so that's going to extend the big toe, and so on. So hopefully if you come across those on state boards, again, you can let me know and I will add muscles and make things harder for the next person. And then on page 121, if you like to look, it groups all of the muscles and it gives you nice diagrams. So they pull out the action and then list the muscles that contribute to that action. So you can kind of get maybe more of a broad understanding of the actions. So once again, I hope that helps you study in terms of testing purposes for your comps. Make sure you know your origin, insertion, action, innervation. The competency will be just like it was for the upper extremity. The format will be the same, and we will have a 10-point quiz that will be similar with matching, perhaps matching, multiple choice, listing, fill in the blank, that kind of thing.